Welcome to ADA After Hours, which will be driven entirely by your questions. Guys, we've had a lot of questions on the consensus process and perhaps objections to the consensus process, and also even claims of bias. Mahiri, essentially various questions are related to why certain groups were not consulted and why the members of the broad associations weren't consulted prior to the publication. Can you, obviously this was a mammoth undertaking anyway, but can you give us some insights?
Sure. So Peter, we genuinely tried to be as consultative as possible. As part of the consensus statement, the ADA approached peak bodies. So as I said before, whilst there is a wealth of experience, and I know there are people with differing views and different approaches to Ankyloglossia that felt that they had something important to contribute, and I recognise that. I think we all recognise that. But essentially, this is already the biggest, most broadly consultative consensus statement on a topic like this. And it's important to remember that as part of this, the ADA approached these peak bodies that represented professions, not specific interest groups. And they were asked to nominate a representative, which was completely up to the organisation. After that, we met and we developed the consensus statement, and the consensus statement was then returned to all the organisations for them to them within an organisation look at it and comment on it. And that includes in the ADA. So there were multiple dentists consulted through the process who had the opportunity to comment on the consensus statement. So it really did, I suppose, go through these multiple stages of consultation. And one last point, I guess, is that there have been other consensus statements released in the United States, in New Zealand, and these are absolutely consistent with this consensus statement, which, given different processes and different groups, the American one was very specifically otolaryngologists, and the New Zealand one was the New Zealand Dental Association, and different methodologies, but we all came to very similar conclusions, which adds to, which leans to the robustness of this statement.
Corinne, did you have anything to add?
Well, I think there were a number of other organisations that were approached that did have basically important input in this topic, and some of them declined to continue or provide representation. So I think we were as broad as we were able to get, and certainly gave everybody an opportunity to come to the table.
All right, so as a question on a very similar theme, could you please comment on why there were no dentists with any significant involvement in tongue tie surgery in the working group? Can we stick with you, Corinne?
Sure. I think, as we've outlined again and again, this was not individuals coming in with their own particular experience or philosophy. This was an organisational group where we had representatives representing the organisation per se. So if you want to ask me my own personal experience in being a wet-handed person, yes, I can talk on that, but that could be after hours or whenever you feel appropriate. But we were representing a very diverse group within our specialty.
All right. And Mahiri, another question for you. Could you please indicate if there's the opportunity for this statement to be revised based on professional feedback reflected in a petition that has been circulating?
So this consensus statement is complete. Certainly it's evidence-based, and up in front in that statement is that there will be revisions made down the track when important findings emerge. Generally, the ADA tends to review policies every 2 to 3 years. Beyond that, this is, as I said, it is entirely consistent with existing consensus statement. It is completely evidence-based, and there's no reason at this point to change it in the short term.
All right. Well, Corinne, you may have answered this somewhat during the main event, but why is cold steel recommended for neonates specifically?
It's not so much that it's recommended specifically. I think what it's suggesting is that from the literature, there is not a great deal to separate the outcome from particular techniques. However, the room for error and the possible complications are different. So if I'm operating on a 3-year-old and doing this procedure, it would very likely be in a GA scenario where I would have complete control of airway. I would have an anaesthetic and a surgical team around me. I would be able to administer local anaesthetic appropriately and monitor. If I have a 2 or 3 day neonate sitting on mum's lap, and I'm on the second floor of a surgical dental practice, and I'm utilising some technique, I personally would feel that cold steel or scissors would be a more effective and less complex surgical technique rather than laser. That's my preference. Having said that, I've done a laser course 16 years ago. I've had a diode laser. I've gone to Dr. Kotlow in Upper New York State and done his course for 3 days. So I feel that I've got the background to make my individual decisions, but that's not what this is about. This is about evidence and a pathway of safety.
All right. David, we've had some questions about pain relief, intraoperative pain relief. Can you just run through that, your thoughts on intraoperative pain relief again?
Look, it's obviously most important to be safe. And so intraoperative pain relief needs to be considered, but not, I guess, not mandated. Although some practitioners feel very strongly that there should be no analgesia or anaesthesia provided other than breast milk or such after the procedure, whereas others strongly advocate application of topical anaesthetic or even injection of local anaesthetic into the wound bed or potential wound bed. The concern always in the younger age group is toxicity, and I think that has to override other concerns as the children age. The 3, 4, 5-year-old, again, probably in a general anaesthetic environment, operating theatre, you have the backup, so if there is an issue, then that can be better managed.
All right. Michelle, did anyone on the working group either have experience of breastfeeding a child with ankyloglossia, or did you actually speak with mothers who have experienced breastfeeding such a child?
I have my own personal experience with my own daughter many years ago, but I work very closely with many mothers who have babies with restrictive frenulum, in doing breastfeeding assessment and breastfeeding support, and then I'm able to actually follow them up afterwards on some occasions, because for referral to my own facilities, tongue tie clinic, and so I'm able to see that before and after, and that's been at the place I'm working at the moment and the place I was working at previously as well. Yeah.
All right. Well, Emma, let's move to you. The statement doesn't mention what kind of non-surgical treatment modalities are recommended. Can you enlighten us?
Yeah, and I think, as I said when we were in the main portion, when we talk about non-surgical options, we're essentially thinking of different intervention techniques that we can use to address the underlying issue, in the sense of we're advocating for addressing the underlying issue, not the short frenula itself. So if we think that the frenulum is causing issues with nipple pain or poor breastfeeding, we're going to look at managing latch and other underlying causes for that breastfeeding issue before we would then consider it to be requiring the removal of the frenulum or intervention. So I guess we think about positioning of latch, management of supply issues, breastfeeding support. If it's a bottle feeding baby, we might look at specific bottles or specific teats or any other underlying feeding and swallowing issues that may be causing the presenting complaint, such as, say, a baby presents to me as a pediatric speech pathologist with a lot of experience in infant feeding. They're presenting with coughing and choking or bottle refusal, and the mother is concerned that potentially the tongue tie is the underlying cause. I would look at what I know through my years of experience and what the evidence would suggest as why this may present, and look at the things I would do to manage that issue, such as pacing or looking with my ENT colleagues at an underlying issue. and then completing a functional oral exam to look at the tongue's range of movement and how that is contributing to the issue. So I guess the non-surgical options are the options that maybe are looking at addressing what the underlying cause for the feeding or speech issue is, or is the level of limitation of the tongue not significant in the sense of contributing to these issues?
All right. And Emma, sticking with you, we have a question relating to the Webb et al. 2013 study. The question says, unfortunately, this study only researched 3 databases up to June 2012, therefore did not include any research in the past 7.5 years. Are you aware of any more current reviews investigating speech outcomes in patients with a history of ankyloglossia?
Yeah, there's very recent research that's been published in Western Australia by Salt and her colleagues. And they looked at 59 children aged between 2 and 5 years old, and they formed 3 groups. They looked at kids that have had a treated tongue tie, untreated tongue tie, and no tongue tie. And they looked at the lingual frenulum structure and function, the mobility of the tongue, speech production, and then also looked at intelligibility, so how easy these children were to understand. And this study recommended that there was no significant difference between any of the 3 groups, and that performing a surgical intervention for tongue tie during infancy for the sole outcome of improving speech production wouldn't be supported. So this is a more recent study. And there's also other studies by researchers more recently, say Dixon et al., that looked at babies with a suspected tongue tie that presented to a clinic which would normally intervene on 95% of its infants. And they found that by having these children supported by ENT and lactation, a significant drop in the rate of frenotomy and the resolution of these children's issues, hopefully. So I think there are much more recent studies. That particular article was used as the Webb article I use as an illustration of just how much there is out there in terms of the range of quality of evidence.
All right. Well, Michelle, a question for you from a midwife's perspective. Could the increase in Medicare claims and claims by dentists could that increase be attributed to the reluctance of other health professionals to provide a frenotomy service, since that was traditionally done by midwives? What can you tell us about the history of your midwifery profession?
Well, yes, I've heard the stories about midwives who would use their fingernail to just gently pierce under a baby's tongue if there was a breastfeeding or latching issue. I haven't seen that in my time, so I think the difficulty is I don't think I see a lot of women seeking treatment for their baby's tongue tie, because that's easier than finding lactation support. Lactation consultants that practice privately, it is a private service. There's no Medicare rebate for lactation consultants. My professional organisation are lobbying quite strongly for that, because women should have the right to access a lactation consultant without having to access them privately. So I think that does happen. I think a lot of women will seek, where can I get it done to fix the problem, or in case there's a problem, rather than actually seeking lactation consultant support and or child and family health support. Yeah.
All right. Well, sticking with you, Michelle, what training and qualifications does a lactation consultant have? This person is curious as to whether consultants have the appropriate training to identify whether frenum surgery is needed.
I don't identify whether frenum surgery is needed. I assess a breastfeed, and I would use, as Emma would, the Martinelli and the Hazelbacker tool. So it's the 3-pronged approach. It's about assessing the mobility of the tongue, the lateralization of the tongue, the elevation of the tongue, watching a breastfeed, trying to put in some support mechanisms to see if we can improve that latch and optimize that latch. And then I would talk to the mother about going, like, I would say these are your options, and then it's up to her. But I would encourage her to go to somebody where she's going to get that lactation support, or make sure that she can get that follow-up. What qualifications does an international board certified lactation consultant have? We have to recertify every 5 years. It's an internationally recognised qualification. You need to have 1,000 clinical hours in lactation support prior to the exam, and 1,000 clinical hours, and 90 hours of education. And then every 5 years you need to recertify with 75 hours of education. It's quite expensive as well, which is fine, but that's basically what an international board certified lactation consultant is, and that is the only known qualification for a lactation consultant.
Not for the faint-hearted. Emma, I understand you want to chime in.
Apologies, this is actually on the topic before and on the topic of the evidence relating to the request for some newer research around the speech outcomes. But that being said, I completely agree with Michelle. Being a speech pathologist, I had trained for 10 years as a speech pathologist and worked within infant feeding, and then completed my training as an international board certified lactation consultant. And it was quite the process and involved a lot of mentorship and teaching from my lactation colleagues, and a lot of education hours, and then a lot of practical hours. So it's definitely quite an in-depth process. If it's okay to just go back to the last comment when we were talking about, yes please, around the slide, in talking around more recent evidence, there has been a study that has claimed an 89% improvement in speech post-frenectomy. But then, as I said before, when we look at evidence, we need to look at how it assesses what it says it's assessing, and also what the outcomes were. And there was, for me, reading this as a speech pathologist, the way the outcome in speech was measured was asking the parents whether they felt speech improved, yes or no. And we know from looking at lots of different research in lots of different areas, that's not a robust outcome measure. And also the assessment tool that was used as the diagnostic tool was the Kotlow rating scale, which is based on appearance and not related to function. And certainly in the last year with Dr. Mills's research around anatomy and how the features of the tongue are made up, we know that we can't classify a tongue tie based on just what it looks like anymore, because that doesn't tell us what the tongue is actually doing. So I just wanted to refer back to that article. My nerves at being on the big screen had popped it out of my mind, but I had meant to mention it. So thank you.
Thank you for following up. Emma, sticking with you, and I'm going to say it's partly because of your accent. In the UK, it would be unusual not to snip at birth. Presumably, we're talking about the lingual frenum. Can you discuss this approach?
Oh, I feel, actually, interestingly, I've not worked in the UK for shy of 12 years, and I left the UK within 4 years of practice, and I actually didn't have the level of expertise and experience in infants. So I'm not entirely sure what they do in the UK, to be completely honest. So I don't know if I can answer that question, and I don't want to talk to something that I don't really feel I have knowledge about.
Michelle, do you have any insights?
I can say that from my experience in one of the hospitals that I've worked at or am working in, that when I first started, it was quite common for babies to have their tongues released on day 1 or day 2. That's changed completely now, mostly because of the education of the staff, and also having a consensus statement like the one we have now, where we've got some guidance around a non-surgical pathway and breastfeeding assessment. But yeah, I can say that I think it does happen, here in Australia as well.
Yeah, very frequently. Yeah. Well, David, a question for you. Are you able to comment briefly on the treatment of ankyloglossia in adults, including scleroderma?
Oh, not specifically in scleroderma, although ankyloglossia in adults, predominantly it's in my experience, and again this is, I try to steer away from anecdote, but teenagers coming through with body issues with either the appearance of their tongue being different to their peers, or an inability to lick ice creams, or use your imagination about other things, that and that's where the release of a lingual frenum in a younger adult or adult might be undertaken, certainly in my practice.
Okay. Michelle, we've also had questions from our rural viewers asking about how the WHO recommendations on breastfeeding can really be applied in settings where just geographically there isn't the same access to specialist care. Can you help us out?
Specialist lactation support.
Lactation consultant, I think, is the thrust of the question.
Yeah, it's I am aware of the challenge of lactation support or even midwife support and child and family health nurse support rurally. I think it's a matter of I don't have a magic wand. I wish I did, and I think that every woman deserves that support. The only thing I could suggest is just this current staff broadening their scope of education to become an international board certified lactation consultant and access education around that would be the suggestion that I have. There are quite a few online courses for lactation consultants or people preparing to sit the international exam that match the curriculum of topics that you would like. And I think the other thing is recognition as a Medicare healthcare provider is going to help as well. Yeah, definitely.
All right, and Emma, I understand you'd like to weigh in?
Yeah, I just think in terms of the current climate and our use of telehealth and telemedicine as the COVID pandemic has progressed, I certainly think there are a lot of skilled lactation consultants and practitioners out there that are offering assessment and support in more unusual ways. I certainly performed a tongue tie and breastfeeding assessment on a baby 500 kilometers away recently. And I utilized things such as screen sharing using the Martinelli and et cetera, et cetera. And so I think, as Michelle alluded to, there's definitely online tools for education and upskilling, but also looking further afield if you are wishing to have an assessment for a baby you have concerns about, looking for those providers that are competent in the use of telemedicine. And also thinking about, I know it sounds a bit cliche, it takes a village to raise a child, talking to other mothers and getting breastfeeding advice and looking at the breastfeeding journey as a whole in terms of what issues am I having, and is it necessarily a tongue tie and I need a specialist to come and see me, or is it actually a breastfeeding issue that another breastfeeding mum or my community can support me to problem solve through? So I guess it's thinking a little bit outside the box as to how do I problem solve the issues I'm facing as opposed to how do I get surgery, would be my just addition to that.
Emma, here, you had something to say to that point as well.
Yes, I think, we see this with so many health-related issues where, certain groups in our community unfortunately don't have the same access to care. And I think this is one of the strengths of a consensus statement like this, that we should be demanding that people who live in rural and remote areas do have these essential services. It's clear that it's absolutely necessary in the management of something like this. And the increasing rates do reflect the community awareness, and it was certainly something that was noted and discussed in the consensus development, that we acknowledge that there are some limitations to accessing care, and that we hope that this will be a powerful way of advocating for that as well.
Can I just add to that? The Australian Breastfeeding Association is an amazing support for breastfeeding women, and that doesn't really matter where you are in Australia. There's a 24-hour helpline number that's free of charge that the Australian government funds, and they offer amazing services, online chat sites and telephone and groups and lots of help. So it's important that women are aware of that service. Yeah.
Well, sticking with you, Michelle, can you explain what happened previously when freedom surgery was more rarely done? Is there any evidence to show that breastfeeding success rates have improved at the same rate as the procedure?
I don't know that I could answer that. No. I suppose in my time as a lactation consultant, I have seen a remarkable increase in the number of cases that are called or diagnosed as a tongue tie, or often it might be the medical person who checks the baby after birth and writes it down in the baby's blue book. And but I can't say, I can't really answer that question because I don't sort of,
Another way of addressing that question is to flip that around. Is there a lot of evidence to suggest that prior to the increase in the surgical management, that breastfeeding issues were of a greater concern?
Mahiri, what are your thoughts?
Well, I think it's important to remember that, when it comes to breastfeeding issues, that the main causes are, quite broad. And so I think, I'm putting my researcher hat on, I think statistically it will be quite difficult to show that these very high rates necessarily correspond to an increase in the population. I think you need quite specific, sort of cohort studies to look at that kind of thing. I think it's such a heterogeneous, number of causes that could lead to breastfeeding problems. It's hard to evaluate with that kind of measure. What we do know is there have been some studies looking at sort of where ankyloglossia, frenectomies are performed, and that seems to suggest that there might be some socioeconomic factors, and perhaps more affluent areas have higher rates, and that's again, it's preliminary evidence and probably needs to be investigated further as well. So it's interesting. You can look at sort of some of these population trends, but there are limits to that as well.
Can I just add to that too? The Australian data collection on breastfeeding rates is still, we just recently on a World Breastfeeding Trends Initiative report scored very low, or actually nothing on that, because we don't have monitoring of breastfeeding rates in Australia that's sound. So the latest figures that we have was from the National Breastfeeding Survey, in 2010. That was 10 years ago. So that's a jurisdiction of the National Breastfeeding Strategy, where they're looking at a good system of monitoring breastfeeding rates in Australia, but we don't have that data at the moment. Yeah.
And Emma, I understand you had something to add?
I think it's pretty much been covered, but just my thoughts are that we need consensus amongst ourselves on what contributes to tongue tie, how we assess it and how we diagnose it before we can then use it in terms of any kind of outcome measure or to look at this data and population. So I think it kind of highlights why consensus statements are so important, because they give us a starting point for us to then be able to start collecting more reliable data if we're all coming from the same place.
And David, going back to the possible reasons for the increase in these procedures, this question relates to whether financial benefit for the providers of these treatments might be a factor in the increase. What would your thoughts be on that?
Look, I would hope not, would be the answer. I don't think financial gain's a motivation for any type of surgery, in fact, or any intervention. Don't forget, surgery, as we talked, can be harmful, and certainly I think should be avoided wherever and whenever possible. So it would be some disappointment if financial gain was a motivation for undertaking this procedure.
Corinne, is there much training in ankyloglossia or frena in general in the specialist paediatric dental course?
It has become more a part of the curriculum, depending on the institution that you carry out your registrar training, whether it's associated with a teaching hospital, which mostly it is, whether there's a children's hospital associated with it or not, then that gives you some access or maybe not. But we do get quite significant training in oral surgical procedures, particularly dentoalveolar surgery. So we are used to removing supernumeraries, providing exposures, doing some soft tissue resection. So having access to frenal surgery is certainly something we would see. And I think the more recent graduates are probably getting more exposed to it than possibly even I did some 25 years ago.
Michelle, from your perspective, there's a question asking, is there any evidence that actually links frenal surgery to oral aversion? Are you aware of any studies, or has that been your experience?
No, I can't say, I'm not aware of any studies, and I can't say that I've ever witnessed that or experienced that with any of women that I've cared for. No.
Anyone else on the panel, have they had any direct insights there?
It's challenging because I feel like the consensus statement is a statement of evidence base, and that's what we're here to discuss, as opposed to our personal experience and anecdote, which is in itself not a strong evidence base to advise such a large group of people how to practice. So I think I might also abstain from that question, but there is no evidence to suggest a link at this stage in time.
All right. Now, a question I'll pass to you, Corinne. By the time orthodontic problems manifest, is that possibly a bit too late for frenum intervention?
I don't think it would be associated, in my opinion, and certainly from the evidence that we've been able to gather, that the lingual frenal attachment would be a very direct complication for malocclusions. As I mentioned earlier, there are some suggestions that obviously in a labial frenectomy, particularly in hand with an orthodontic space closure strategy, ideally the age of 9 to 10, or as directed by the orthodontist, there are some studies that suggest that that is beneficial. The suggestion that if we do the frenectomy early, then we possibly counter the development of a malocclusion, I think, is not something that the science would suggest, and certainly not a reason to carry out surgery for that potential future benefit.
And Mihiri, what are your thoughts?
It's really important to remember that the visual appearance of the frenum changes quite significantly over with growth and development. And so sometimes young children's frenums can visually appear to be quite prominent, but that's and it's very difficult to call a lot of those. And there have been studies looking at how they've changed with time, and it's probably important to remember that can change. And as we know with orthodontics, particularly for the labial frenum, that timing of treatment is not necessarily early. Sometimes doing treatment after might be appropriate.
Mihiri, sticking with you, we have a comment that the American Academy of Paediatric Dentistry point out that lip ties contribute to dental caries. Do you have any thoughts on that front?
Yeah, it is. It's interesting because there are slight differences, but I think they also highlight the fact that there is not good studies on this area, and certainly there really is very little evidence in this area. So I think we all, and I know there are non-dentists here, but I think we recognise that there are very key risk factors for dental caries, and certainly a prominent frenum seems very, very low on the list. So we're talking about dietary patterns, sugar consumption, oral hygiene, these sorts of things are the typical issues. So I think the Academy's statement very clearly does state that the evidence is quite limited and that they need further research in that area as well.
All right. Corinne, do you have any courses are you aware of any courses that you would personally recommend for dentists or practitioners who want to learn about frena and surgical techniques?
I am aware of a number of practitioners who have their own setups and do now currently with COVID stuff online CE and also hands-on. I'm not able to comment personally on those because I've not attended them. But I do know that, for example, a certain number of individuals who have responded to our consensus statement have had their own experiences within this field, and they are obviously out there also promoting this particular surgical technique on their philosophical basis. So there are some hands-on courses people can do. I suppose the caveat to that is that if we can all establish a pathway and a consensus, then we would be much more comfortable that everybody's on the same page.
All right. And a final question, I guess it's heading in the bias direction, just to cover that. Do any of the panellists regularly work together?
No.
No, fair enough. Hopefully that clears that up. Look, I'm afraid we're out of time, and we've gone well over time. And I'm sorry we didn't get to all the questions. There are lots of good questions, but just not enough time. So, Mahiri and Emma, David, Michelle, and Corinne, thanks again for joining ADA Interact and sharing your consensus on Ankyloglossia and oral frena.
Thank you.
Thank you.
Thank you.
Thank you.
And thank you for watching. If you'd like to re-watch this discussion, it will be available from your respective peak body, including the ADA members' CPD portal. Thanks again, and see you soon on ADA Interact.